Able to see now,
How
sir.
about now?
We are able to see the changes, sir.
Yeah, okay, perfect. Sorry about that. Always some
Yeah.
technical glitches that are
Okay.
there.
Shall we start, sir?
Yeah,
Yeah. Okay. So, good evening, everyone. Good evening, friends. I'm Dr. Ramesh. I'm Chief of Critical Care Medicine, Continental Hospital, Hyderabad. With us, we have Dr. Venkat Kola. He was past Vice President and Executive Member of ISCCM. And today we have the topic, a most interesting topic, that is AI in critical care medicine, wherein we'll be covering AI in sepsis, that is sepsis prediction models, and sepsis like phenotyping of sepsis, and then the prognostication and the management also. And ventilator settings like in the AI in ARDS or AI in weaning process of ventilation, and AK prediction models, and sepsis related immunoscore. So all those things we are planning to cover, and AI in vital monitoring. So especially in remote monitoring devices where we'll be monitoring the vitals like heart rate, blood pressure, and all. So for that, the optimization of the alarm settings, and then to reduce the false alarms, and to avoid alarm fatigues and all. So what is the role of AI in that module? Let us learn from our expert. It is none other than Dr. Piyush Mathur, sir. I think everyone knows about him. Sir is a senior anesthetist and intensivist from Cleveland Clinic, Ohio. And sir is a founder of BrainX community. And he has done a lot of work in AI, in critical care medicine, and in the clinical medicine also. Sir has done his graduation from AFMC Pune, and his like post graduation in anesthesiology and intensive care, all from United States only. Welcome to you, sir.
thank you. Thank you so much, Dr. Ramesh, and thank you so much, Dr. Kola, for having me here. And I think we could cover a lot, but as we discussed on the WhatsApp, I'll try to keep it practical. I'll try to make it real. So there is a lot of research work and a lot of development work, but where a lot of people don't relate to AI is that they don't relate to AI as something that is real. They think like, yeah, there's some algorithms, maybe in US, somewhere else, but I want to make it real. I'll give you some real examples of AI in application today, and I'll also leave you with some thoughts about how you can get started with this, with some examples from India itself. So I'm going to focus on real world examples. I'll show you what's happening in the world. You probably are seeing that happening around you too, not just in healthcare, but in real life. Show you some of the examples of how things are evolving, not just in critical care, but outside of critical care that we can benefit from, and then bring it back to critical care. So I can show you here that the world is changing, where there is a lot of work that is being done for use of AI in healthcare. This particular example, and I'm going to play this.
In this video, we highlight the smart
You may
tissue
not be,
autonomous
are you able
robot,
to hear the
also
sound?
known as STAR. STAR is a transformative surgical robot for autonomous soft tissue surgery.
We are able to listen.
It consists of two
Okay.
lightweight robotic arms, a robotic
You're able to
tool,
hear the sound,
a novel
right?
3D endoscopic camera, and a surgical workstation to monitor the
We are able to
procedure.
hear the camera, like
STAR's
video
trademark
sound.
has 7 degrees of
Okay.
freedom and redundant
So
force sensing that enables a
what's
wide
showing
range of
you
motion
over
with safe
here,
operation. Additionally,
let me just
STAR has a
bring
gravity
the sound down a little bit. What it's showing you over here is a robot that was trained using AI, and it can go ahead and do autonomous intestinal surgery. So it can be deployed in a patient, and then it can do this autonomous suturing by itself. So this is not human guidance. Humans are only getting the laparoscopic ports inside the patient, and they're just putting some stay sutures over there so that the robot knows where to go ahead and suture it. But what you'll see over here is that the robot using AI and AI vision will go ahead and do the surgery for you.
When a surgical plan is not consistent with a three-dimensional point cloud, the surgeon can initiate a replanning algorithm to generate a new plan. STAR creates an anastomosis by applying a running suture along the back wall of the small bowel. A human assistant removes all loose thread from the surgical field to prevent the formation of locking sutures. Stark completes the second half of the anastomosis by using a running stitch to close the front wall. Sutures are applied with uniform spacing as determined by the surgical plan. At the end of the
All
surgery,
right, I'm going to pause at that. But what you saw was this robot, once it's put into the inside the patient, it's going ahead and doing this intestinal anastomosis. Again, this is currently in research. This is in trials. There is a subsequent one that has gone on to develop to do cholecystectomy, that is to remove the gallbladder out too. Dr. Ramesh, if you mind, can I change my screen to another slide set? Just can
Sure,
I
sir.
pause
Yeah,
for
yeah,
1
sir.
minute?
Please.
Please.
Good evening.
All right. I want to show you some more examples to get you excited over here.
Dr.
Just
Venkat
give
has
me,
joined us.
Yeah, yeah, sir. Good evening. Sorry, I had some technical problem. You can
no
change. You
worries.
can change, please.
Yeah, no worries. No worries. Just give me 1 minute. I'm just opening the other screen up. I want to show you more. Yeah, I want to show you some real life practical examples of these. So I want to show you some videos that you'll relate to in critical care. All right, you can see my screen now, right?
We are able to see, sir.
All right. So this is what's happening in the real world out there. This is what's going to come to you. What we have known and what I'm showing on the screen is the traditional way of looking at AI. You know, we have thought about it as machine learning. We have thought about it as deep learning. We have thought about this as neural networks that are there. But now there is even more progress that is being made with that. And why is AI important in today's age? You are probably seeing this change happening right in front of you. We have gone through the different phases of industrial revolution, the initial agricultural revolution, but everywhere around you, everybody is talking about AI. You just had the AI summit in India at ISCCM. I'll share some exciting pictures. AI was very prominent left and right. So you're already seeing that change. One of the big changes that happened in 2022 was when ChatGPT came and you were able to interact directly with AI. Before 2022, what was happening was that there were a lot of nerds like myself who were trained in computer programming. We were working on writing a lot of these software code to make AI work. But now everybody is using Gemini, they're using ChatGPT, they're using DeepSeek or other models right on your phone. You have an application. I bet you a lot of you are already using that, right? And it's amazing how that is transforming. I was watching IPL recently. I'm sure you all are watching it too. I hope Hyderabad is your favorite team. They're doing very well. But in IPL, you see all these ads, even in World T20 World Cup for Gemini and ChatGPT, right? So it's made it real. It's gone to you in your hands, and that's what people are using. So let me also show you what's happening around you, not in just in critical care, but in all other healthcare specialties. This is a research work that we do year over year. We have been doing this since 2019. And we look at the publications related to AI care from the year before. And then we categorize them for different healthcare specialties. Now, when our team started doing this research, there were around 3,000 publications based on PubMed search in 2019. But then last year, there were 49,000 publications. So what we have started doing is using AI to sort through these publications to show and demonstrate what's happening in the experiments. So what these numbers represent are experiments. So these exclude editorials, reviews, viewpoints, all those are important. But just look at the number of experiments that are happening, the research that is happening across different healthcare specialties. If you see critical care, although we live in a very data-rich environment, you can see it's still a small blip over here. And I think that's a call for us to do more in this space. And it's not just research, but also this research is leading to a lot of development. And this is just a representation of FDA approved algorithms. So these are FDA approved. These are available for use at bedside in US and many other countries. And I'll show you some real examples that are available now in the market for use. But it's not just research. Previously, everybody used to think, yeah, AI will be the future, AI might be the future, but this is becoming more and more real. And you know what makes it really real for people in US is when you can make money out of it. So this is a paper where they looked at AI algorithms that you can bill for. And these are a lot of image-based AI algorithms, so like for MRIs and ultrasounds and CT scans. But you can actually bill for these in US, and you can get reimbursed for it. That's where it becomes sustainable, that eventually in the future, you can pay for these and it becomes sustainable. So Dr. Ramesh was talking about sepsis algorithm. This is one, and again, I'm not trying to promote any. So this is one that came out of Johns Hopkins, just received FDA approval this week, where using machine learning methods, it can predict patient who has sepsis or will be developing sepsis. And what research has shown with this algorithm, this is one of the examples, that if you provided timely alert to the clinician, it can lower mortality, it can improve the SOFA scores, and decrease length of stay. So there is increasing evidence, and there are algorithms that are making it to bed spaces. This particular algorithm is in trial and in use at the Cleveland Clinic currently. So these are real algorithms being applied, being used already. Another one that you might know about is hypotension prediction index. So it may not just be sepsis that leads to hypotension. It might be other kinds of shock that might be there. And we might want to predict them both in the ICU or on the floor. But this one uses arterial line waveform, so you can't use it on the floor. This is hypotension prediction index from one of the manufacturers, again, FDA approved, where it can predict hypotension if a patient has an arterial line. And now they actually have a non-invasive device also through which you can use the pulse, similar to pulse ox waveform, and get a prediction for hypotension 5, 10, 15 minutes ahead of time. Now, you might say like, okay, I don't trust these algorithms. I don't believe in this algorithm. But when you look deeper at the build of this algorithm, what it does is it looks at the cardiac cycle. It looks at the pulse waveform. Now, I'm sure there are a lot of senior critical care physicians in this group, and a lot of us were trained in feeling the pulse. So the first thing we would do is feel the pulse of the patient. And actually, many senior critical care physicians, just feeling the pulse would be able to tell what kind of shock it might be. And many times we used to feel and say like, okay, it's cold, clammy, it's warm, but like not perfusing well. So different types of, so this algorithm looks at this pulse, but what it does is it looks at a lot of different features of that pulse. So it is looking at the height of the systole, the duration of the systole, the height of the diastole, the duration of the diastole. So like that, multiple features, and that's what it says over here, the waveform features were used to build this machine learning algorithm. Now, in real life, you really cannot interpret a lot of these features. They use more than 2.5 million features. And there were some combinational features too that we just can't do humanly. So combinational features are like the height of systole plus height of diastole. That might be one combinational feature. So out of those 2.5 million features, they picked the features that were predictive, and through that they developed this model where you can look at, where you can feel the pulse or interpret the pulse waveform, which represents basically cardiac cycle, and then be able to predict who's likely to develop hypertension in 5, 10, 15 minutes. So it's a lot of rigorous science. That's what I want to share. A lot of people think that it's just black box. It's something that is not real, but there is a lot of rigorous science that is behind that. And here is a case example for this. As the mean arterial pressure starts to drop, you can see that the hypotension prediction index is going up to 100. Higher the value, the higher the prediction capability for this. And that's what it's showing you, that at this point of time, it's predicting that a hypotension will occur. And if you see a map of 65, it's minutes ahead. At bottom, this is minutes. It's minutes ahead of hypotension occurring in a patient. So this has been trialed in real world. This is available in the real world. This is FDA approved. This is in use for prediction of hypertension at many, many centers, both in the operating rooms and in the ICU. I want to show you another example. This is EKG-based ejection fraction estimation FDA-approved device and algorithm. So just looking at the EKG, can you tell who has low ejection fraction? So think about all these different places where you may not have readily available echo or an ultrasound machine, or the clinicians who have the skill set. But EKG, even nurses can apply and get it for you. So if you wanted to screen a patient readily, sometimes on the floor, sometimes in a place which is distant from some of the key locations, you could use this to at least identify, is this a patient who has low ejection fraction, and then decide about how you want to treat this patient. This is real, FDA approved, in use currently. Talking about echo, many years ago, in 2018, this paper was published in Nature, where they showed that some of the AI algorithms, this is a convolutional neural network, a very commonly used algorithm for image interpretation. It could interpret the echo images to give you the ejection fraction, sometimes even better than the echocardiographers or trained cardiologists. So this was researched in 2018, but what has happened since is you will see this. Again, this is the example, or this is the figure which shows how it was built. But what has happened since then is, let me play this video here. What you will see over here on this right-hand screen is somebody who's performing this echo, applying this echo probe to the patient. And the first thing for echo is to capture the images. Now, this echo is providing you with, this echo device is providing you with real-time guidance on where to put the probe and how to get optimal images. So I'm just going to let you watch this. So it's giving you this real-time guidance to do this. You know, we do a lot of training for teaching echo. And even then, we sometimes have a hard time getting good images. Now, in this case, published in JAMA, they showed that if you provided novice nurses, so they have not used these echo devices, but if you provided them with these AI embedded echo devices, they could capture all these different assessments as good as sonographers. Now, that really democratizes a key skill set. So think about walking into the ICU tomorrow, or being on the floor, or taking care of a patient remotely, and maybe you can't be there. Maybe you don't have the right people who have been trained in POCUS, but with these AI guided echo devices, you could put it on the patient, have it guide you where to get the best images, and capture those images so that you can interpret yourself. That is what's happening with echo. Now, let me show you what happens after you get those images, right? So after you get those images, you want to generate a report. So here's a model that has already been developed. It's already validated and tested.
That are uploaded from a single study. The view is assigned to each of them. So you can see in the top left is the view written in blue. And
so what you're seeing over here are the images that have been captured. What you're seeing on the right and in yellow is the model writing the report by itself. So this is not a physician writing the report, but just looking at a group of images. So it has been trained on which group of images to look at. It's writing a report initially in yellow, and you can see the report on the right side evolve for you. This is all autonomous. So somebody can capture the images for you, and then the model can generate the report for you.
Different views are being analyzed for highlighting how we need to weight the different views for each section, we need to prioritize different views. Yeah, so these are the full interpretations. Once the algorithm finishes, it's going to give a full report. So you can see that it's a full length report analyzing everything section by section.
Isn't that amazing? So all the way from capturing the image by a novice person, think about the help it can provide for education. Previously, I used to share some of these apps trying to teach my trainees on how to perform echo, but all that is becoming much, much easier so that you focus on what you need to do for the patient rather than trying to deal with some of these technical issues. And here is a study which demonstrates that AI-guided echo in use in critically ill patients, evaluation done between novices and expert echocardiographers. When you provide them with AI-guided echo, there is no difference. Now let's shift to monitoring a patient. What about monitoring them in the ICU or on the floor? Can AI help with that? And these are the newer models. That's why I showed you like the prior models, they are all being superseded by some of the newer models. Again, this is from a company in India that has developed this. So you can monitor the patient over here. And the AI is detecting a change in the breathing pattern. It's showing certain alarms and alerts so that you become aware, just like Dr. Ramesh had said that I'll showcase. And then it's asking you what you would want to do next. This is not a human asking you to do this. This is not a nurse monitoring, but this is the AI in the background monitoring the patient. And then when it perceives a change in condition, in respiratory status, it might be sepsis, it might be COPD exertion, it might be some other condition, it alerts you and it guides you so that you can focus on what you need to do next. Now, when you detect that there is something wrong, of course, you're going to measure a lot of different things. This is our work from 2018, working with Carnegie Mellon. We wanted to generate diagnosis. We wanted to see if AI can help us generate diagnosis out of it. So one thing is to detect and see there are signs, maybe from echo, get some EF estimations, from pulse, from the hypertension prediction index, be able to predict that hypertension is going to happen. But once you get all these initial signs, symptoms, and maybe initial diagnosis together, can it generate the diagnosis for the patient based on all this data? This is what was our work in 2018 or so. And we showed that, yes, if you input all this information into the different models, and now the models are much, much superior than what we had used way back when. What these graph lines are showing are high accuracy of predictive models for generating diagnosis. These are all ICD codes that are over here. And you can see with a great deal of accuracy, they're able to predict these diagnosis codes. So it can help you with diagnosis too. Now, what about looking at treatment patterns? So you might want to look at the treatment patterns, because today in your ICU, there might be 20 different patients, but who's doing better, who's not doing better? Maybe there is a clinician who's sticking to the guidelines or the protocols of your ICU, but then there might be others who are deviating from that. So how can you monitor these patients for appropriateness of treatments, and can you do that? And also look at the cost of these treatments, because there might be significant variability in cost. So this is our work from a few years ago, where we deployed this AI, and we wanted to measure how the adherence is. And once we deployed it, then within no time, we were able to see how these patients are behaving. And here in this graph, we are showing at different points of time how these patients are behaving. We are even able to measure and monitor the cost for these patients. We are able to look at different groups and see how they are behaving, whether their outcomes are better or worse. So you can monitor even a group of patients, sometimes way more than what we usually can do on an Excel sheet in a more meaningful way. Now, a commonly asked or a commonly made comment is, well, what about procedures? Can AI help with procedures? So I actually started with one in surgery, but this is what's coming uh, to the critical care world and anesthesia or pain management world. This is a robot. This publication was a few years ago, where it can help do blood draws or can help you start IVs. And think about all these patients who are very, very challenging, difficult to get intravenous access. There are these robots that are being developed that are coming for. There are robots that are being developed that will help you with intubations. They are already under trials in different places. This is an example where an ultrasound guided pain block can be done for the patients in pain in your ICU. Maybe they have had trauma, maybe they have had surgery, they are post-op in your ICU. And what AI is doing is not just showing you the needle trajectory, but it's also labeling the different levels of the abdominal wall so that you can deposit your favorite local anesthetic at the right place and hopefully do it much more safely. So robots are coming paired with AI, supported by AI, that can help you with better guidance. Here is another example or a use case where we looked at patient comments and we wanted to hear patients' voices. So we collect a lot of survey data, a lot of comments. In India, you might see it on Google reviews or Yelp or other places where there are surveys done for hospitals or hospital care. But what happens to those comments? How do you analyze those comments? Sometimes there are a lot of comments over time period. That was the problem that we were trying to address. So we built a algorithm or compiled two algorithms to help process these comments and then give us what are the key problems that the patients are pointing towards. So we just wanted to look at the negative comments in this use case, and we found that within a minute, it could tell us or interpret 15,000 comments and tell us what are the key areas where we can deploy improvement. So it can make it much more efficient. So as you are talking to the patients and you're capturing those videos sometimes, or you're creating reports, AI can help you interpret those and tell you what are the concerns patients are raising, what can you address, not just for a single patient, but a group of patients, and that's where it can help you. Another common comment that I get is, well, AI cannot have the empathy like a doctor. So here's an interesting study where they looked at uh, patients asking physicians questions versus patients asking AI chatbots such as ChatGPT questions, and then they wanted to measure whose response was more empathetic. So not just accurate, but also whose response was more empathetic. And what they found was that the chatbot responses were more empathetic. Now, there was a reason for that, because when we spend time with the patients or when we are trying to address things to the patients, we're usually very direct. We are usually pressed for time, although we are empathetic, but we try to convey it in our own way. Whereas the chatbot, what they found was using a lot more words and a lot more different words that might make it sound more empathetic. But trust me, algorithms don't have any empathy. They can appear to convey empathy. You can actually, in your chat GPT, make the response more empathetic. Now, what's the use case for this? So think about, like, if you're responding to somebody, if you're responding to a patient's WhatsApp message or patient's email, you can have chat GPT take your response and you can say, make it more empathetic, and put it in back in the WhatsApp, and it will be more empathetic than what you would have designed. So you could just put one or two sentences and say like, hey, make it more professional, make it more empathetic. Same thing when you're responding to others, you can actually have personalization for different levels and do it that way. And you might find it very, very helpful. So we published this a couple of years ago where we talked about a whole different level of use cases and engagement for clinicians. I showed you numerous examples already, practical ones already deployed, but it's about time that we get engaged with AI. So I'm going to leave with some of these thoughts for you. So should you try to do it yourself or should you try to work or collaborate with us? Well, the answer for this is very, very simple. It's a very deep science. I don't think you can do it all by yourself. You have to work with others to do it. This is a publication that we came out with to address one of the most common questions: how do I get started? So if you're thinking about how to get started, how to upskill yourself for AI, you might find this publication helpful, where we start with set a goal for yourself. You might have an idea today that I want to solve this problem in my ICU, and maybe I want to develop a company. Whereas you might want to start smaller. You might say, I have this idea and I want to do some research. Maybe I want to present a poster at the next ISCCM. So whatever your goal is, start with a goal. Or it might be that I just want to uh, learn more about the basic language or the basic terminology for AI. So set a goal first for yourself. We try to address this common question: do I need to learn programming? Not everybody has to learn programming these days. There are no code tools that are available. You can work with others, but we try to address this and help you with your goal in there. Then you can measure your success, so define success and use certain resources. We provide a lot of resources in this publication, so you can look at this and you can find that. But the most important thing is getting started for yourself. And when you talk about getting started, most of people say, well, I don't have the data to get started. Well, that can be a hurdle, because for ICU, there are a lot of open source data sets. I've listed a lot of these over here. These have been heavily used, heavily published. So that cannot be an excuse that I don't have access to data. These are open source data sets. They require a data use agreement, which is that I'll use it only for research, not necessarily for commercial development, but those are already available. And here is an example from India. This was just released recently from my friend, Dr. Tav Pritesh Sethi at IIIT Delhi. And this is in collaboration between IIIT Delhi and AIMS. This is a PEDS ICU data set, but it's open access, and hopefully you will use it too. PEDS datasets are very rare, so I congratulate this team on making this resource available to rest of the world. But this is from India. What about upskilling yourself? So there have been a lot of these datathons that have been occurring. This is an example for the one that I participated in 2020. This is at the Society of Critical Care Medicine. They have been doing these datathons. And we worked through this and had a great team. We even published our work through that. And then we won the first prize later on at the European Society of Intensive Care Medicine Datathon. So even European Society has been doing this datathon for quite a few years now. But what's amazing is that Indian Society of Critical Care Medicine did the very first datathon this year itself. So we were there, and you can see in these pictures, it was amazing to see such great talent right there in India. So we did this in Chennai. IIT Chennai students were here. There were 9 teams. There were 90 participants. You can see some of them showing or making presentations about the work that they did in 48 hours. So you have the data, you have the compute resources, you have the people, you have great talent, so it cannot be an excuse anymore. And you have your own AI models in India. So Servam, if you don't know, just like ChatGPT or otherwise, is an Indian AI model. You can use it today. It's readily available. So there is really no reason why we can't make these models and do this work in India. And I'm not going to go through all the challenges, but these are real. I do understand there are a lot of problems with AI. We need to solve them, and that's some of the work that we have been doing too. Thinking about clinician acceptance first, because even if you show the best model, I showed you the example of hypotension prediction index, even if it's performing very well, clinicians may not accept it. This is a study from our own institution where we looked at application of hypotension prediction index in the operating room. What we found was that clinicians were not accepting. So there is a lot more research that needs to go in that. Is it giving the advice to the right clinician to the right time or not? Why are clinicians not accepting when the accuracy of the algorithm is good? There's a lot more work that needs to go into this. And there, from the same algorithm, there is this paper that was published showing biasness in the algorithm. Since then, there has been work done to understand why that biasness might be there and how it can be rectified. So there is a great opportunity for a lot of us to get engaged in trying to understand these models better and their application across the world and evaluate them. So our team built this human evaluation tool. So if you're using models like ChatGPT or Gemini, these are some of the frontier models that you might be using for diagnosis or for interpretation. We built this tool. It's open access. It's ready to use. You can use it today. We don't charge anything for this. You can use the metrics over there and you can measure the output. So you can put something in ChatGPT and you can ask it to generate a response, and then you can measure it using human experts, or you can rate it using human experts and get that. So a lot more work needs to go into evaluation of the output of these models. In the last few minutes, I do want to address the fear. There are a lot of people who are very, very afraid, and there is a lot of hype about AI. They are very afraid because people are saying that people will lose their jobs and we need to be worried about it. Well, some of that I'll acknowledge is true, but I think there are things that you can do to mitigate that. So first, let's address the issue of people losing their jobs. So Geoffrey Hinton, Nobel laureate, he received Nobel Prize and also called the godfather of AI in 2024. He said, we should stop training radiologists because it's very clear AI is going to take over their jobs. And what I show you is a graph here from a publication where it shows that since he said this in 2016, the total number of radiology training programs, the total number of radiology position, and actually the demand for radiologists has only gone up. So I actually apologize for that. He said he misstated it. He didn't understand this well. And radiology, as I shown you in one of the figures previously, is doing the highest level of research in this. So what we need to do, the world is changing. It's changing right in front of our eyes. We are going back to the moon. I think we need to get engaged in this space. So let's evolve together. Let's build it together. I applaud the critical care physicians in India who helped and supported the Datathon in India. The models themselves are changing. They're changing from the old models to the newer models. Older models used to do only one task at a time, used to use only one type of data at a time. But now these are multimodal models that are coming. These are being researched. These are being developed. These are being applied. This is an example of one in being applied in cardiac surgery and cardiac ICU, where you're taking not just the values of the vitals, but you're also taking waveform data and then interpreting them together. So not just waveform, not just values, but taking all of those together for interpretation. This one is an example from the award-winning work done by one of my friends, Dr. Anirban Bhattacharya, who was also the organizer for the ISCCM Datathon. AI agents, which will do things autonomously by themselves, are coming. This team, which won the ESICM Datathon Award, first prize, they built this AI agent, which is a respiratory agent. And what it can do is a lot of these different parts of ventilator management or respiratory management that we do. So it can provide guidance for this. It can tell you when somebody might need to be intubated, optimizing PEEP, when somebody is ready for extubation, and how to optimize the different parts of mechanical ventilation. So a lot of guidance is coming, and a lot of this AI is becoming autonomous. three different types of approaches. One is get the best quality data. The other one is get the best quality model. And the third one is make sure that all this data modeling and all aligns with human. That's where we come in. And that's where you come in. That's where we have to ensure that the AI that is built is validated and tested by us. And that again is a great opportunity for us to get engaged with engineers, with developers, with these companies, so that we can develop it with them. We can, if they've developed it, we can validate it, we can test it, we can apply it, we can see the implementation is working or not. If it's not working, what needs to be done to optimize it so that it helps us rather than it helping itself. Some of the key books from recent publication, and to conclude, algorithms in critical care are growing in use. Validation is extremely important. You can't just take an algorithm and fit it into clinical space. You do need to validate it. And that's where clinician leadership like yourself is extremely important. Evaluation frameworks are already there or are being built. We are at the forefront of doing that. And the key question that I try to address is, can these algorithms, these AI algorithms, deliver safe care? This is Gene Kranz. He took the first Apollo mission, and when it had trouble, brought all the astronauts back safely to Earth. And he said, failure is not an option. I say the same. Failure is not an option for us to apply AI to improve patient care. Here is my LinkedIn QR code. You can follow with me. But the most important part of the talk is an acknowledgement to Real Intelligence, to Dr. Kola, his team, the amazing people in Hyderabad who saved my mom's life. She had a life-threatening condition around 2 years ago. I trusted them. I put my mom's life in their hands. They saved her life. She recently revisited one of the clinicians at the hospital, and she's a vocalist. She's a singer, and she was singing to the clinician. So that's truly a testimony to real intelligence. AI can only help real intelligence. You still need the real intelligence. We still need to train our clinicians the way that we train in India. We'll be happy to take any questions.
Thank you, Piyush. That means a lot to us, and thank you for this comprehensive overview. I think there are some questions like humanly the software I think they were trying to find out whether we can have any link for that humanly.
Yes, I'll put it. I'll put it in the
Okay.
chat here.
So what about your development of BrainX and other things which were happening parallelly? You are a clinician. You are also been partly into entrepreneurship, into the technology and AI. So
Yes.
any lights on that?
Yeah, so few years ago, me and a few of my colleagues over here realized the extreme importance of AI. This was around 8, 9 years ago. This was before the hype with the Chat GPT. We realized that it's extremely important, and we created a team called BrainX, and over here, which was primarily clinicians, and we actually found our very first interns from IIIT Delhi. We started looking into this space of how we can apply AI to healthcare. So we are not necessarily looking at how to build the algorithm, but how to optimize them for healthcare purpose. And that's what we have been researching for the last 8 years. We have developed a lot of tools. I just shared in the chat the link to Humanly. It has a link to the application there too. And I'm happy to follow up with anybody who wants to use this offline too after this call and walk them through the use of this. But this is something that we have been intensely researching, whether it is about human-computer interface, whether it is about validation, how can we apply this in healthcare? And how can we validate this? So I'm also putting the link for our research team and the research publications so that you can go through those at your own time. I'm happy to follow up with you too. So both the links are there.
So you pointed out one of those predicting models for the hypotension in
Yes.
non-cardiac surgeries. What are the other predictive things which you worked during this period of 7, 8 years? Sepsis prediction, any new event or during this ICU stay, any adverse event or any sentinel event which can be predicted. So any such models are worked in and around?
Yeah, so there are numerous models for that, not just me personally working on those, but also others, some of those that I showcase. The most common ones that people get into are essentially event prediction models. So you can
Yes.
say like some of these are sepsis prediction models, but you're trying to predict early deterioration. They are a little bit nuanced. They are a little bit challenging. They can help you, but the biggest issue and the biggest challenge that I see, especially in Indian context, and I would urge us to think about how to overcoming this. We did the datathon in India. The biggest challenge that I found was digitized data. We are not collecting digitized data in near real time or real time. So you want to build a prediction model that will predict deterioration 4 6 hours ahead of time, but you need to collect the data in a digitized manner. If it's not digitized, the AI is not going to work on it. uh, Now, there are some companies, I'm not trying to promote anybody in India, who have found solutions to do that without having digitized data. So they took different approach where they took images, digitized the data themselves, and then ran AI algorithms on top of it. But the first issue is having high quality digitized data. So the electronic health records in US have presented this opportunity. I think that is a very big challenge in Indian context. Till that time, you're not capturing, and it has to be near real time. So if you don't capture a few sets of vitals in near real time, if you're going to chart them like 4 hours later, 3 hours later, or something, and you're asking the model to make that prediction that somebody is going to deteriorate in the next 30 minutes or 1 hour, it's not going to work, right? So that's one of the key aspects for these prediction models. You need to have high quality digitized data, whether it's waveform, whether it's values, whether it's images. You do need that. That's one of the key things. If there is one takeaway, if there is one entrepreneurship, one goal that we can solve in India that I can provide feedback to. I've talked to a lot of people. Let's digitize the data over there so that AI can be applied and we can benefit from that.
Ramesh, over to you, Ramesh.
Yes, sir. Thank you, sir. It was an excellent presentation, as
Thank
usual.
you.
You have covered most of the things like how to predict from the arterial waveform to the echo machine, predicting the all the LV ejection fraction, RV ejection fraction, and all, and from the ECG predicting the cardiac output and all. I think another company in India also is predicting the blood pressure modules from the ECG. They are predicting, and they have also exercised. They are compared. We did work along with them for with invasive arterial line monitoring and the extraction of the blood pressure from the ECG. So that is one thing, and uh, means all the time what we have in India is for the clinicians how to go about from that point to next level of exercising in AI. Like you have shown all the database from US, all those things and all. How to utilize that? That training is lacking in our Indian setup. You did a good job and you encouraged us to go to the next level. But from that database, whatever you have shown, I think 4 5 things you have shown the database. So how to work with that and all that technicality is difficult for us as a clinicians.
Yeah, so I think I would say it used to be difficult, but I don't think it's difficult anymore. And that's why I'll put in the link over here the publication that I had shown, uh, which gives you some ideas about how to get started. It has a lot of resources in there too. You can follow me or follow me on LinkedIn or through our website called BrainX Community. We provide all these resources for free for everyone because this is part of our mission to educate everybody. We did the very first, I showed you the very first datathon in India. So we brought a
Hmm.
group of clinicians and a group of IIT Chennai faculty together for 2 days. And they were able to work on developing these AI models and learn from each other. The idea is not to develop a commercial grade model, but at least to develop an understanding of what you need to do. So
Okay.
I'm hoping, and one thing that if I can urge is to follow up with your local groups or teams, whether it is the Hyderabad community, whether it is the ISCCM, that we need to do more of these datathons and more of these workshops. We did the workshop in Kochi also at ISCCM. We did
Yes.
a half a day workshop over there. So if we do more of these, we can break these barriers that are there. At least get you started with that. Also developing collaboration with your local teams. India has a tremendous amount of talent. The whole world is coming to India right now. If you go to BrainX AI research and look at my research team, majority of that is actually from India right now. So we have tremendous amount of talent. Don't hesitate in reaching out to Triple IT Hyderabad, for example. Don't hesitate in reaching out to IIT Chennai. There are professors, there are researchers over there who are very interested in working with you. These are artificial boundaries. Just email them, just pick up the phone. That's how I reach out to a lot of them. Just pick up the phone and call them. Hey, I want to have chai pe charcha with you. And just get them some chai and some samosas or whichever is your favorite snack, and just say like, this is a great opportunity, how can we work together? And you will be surprised how many of them are so eager to work with you. Sometimes we get too tied up in our own world. If you really want to do something, learning is not a barrier anymore. There are a lot of online courses that you can use. These courses, online courses, actually don't cost that much. Previously, if you go to my LinkedIn profile, you can see all the courses that I've taken in the past. Many of them have changed. You can take better courses these days. But you can take a lot of these courses online at your own time. You can even get certified. There's actually an organization called Doctors AI in India that is doing some courses in India too. There are many other organizations that are coming up to do these courses with Indian context. So education is not a barrier. There there are a lot of startups in India that you can reach out to. The resources in India are a lot, and globally, of course, there are a lot of resources. So I don't think there is the same barrier. AI is something that you can do right away. You can get started with right away. If you have to develop a drug or a device, it is much harder for you to do that. AI is much easier to do because basically you just need some of these resources which are readily available at a much lower cost.
Yes, sir. Recently, ISCCM also has started a course of AA in, along with Doctors AA only.
Yeah.
So, yeah.
No, and I applaud. ISCCM is a very frontier organization amongst all the Indian societies. I applaud them and their leadership for having this vision to promote this science, which India itself is leading globally.
The one
Thank you.
question is there, qualities of digitalized data. Don't know what is.
How to optimize the credibility and quality of. If it is directly dragged from the monitor, I think it is a good quality one. But when it is charted, then
Yes, there are
yes.
anomalies. See, the arterial waveform is bad. If it's over dampened, then the quality of that waveform data will be poor too. But there are algorithms that are there that can look at these anomalies and can fix that problem too. If you look at how these are optimized, if that's your question, how do you improve the quality of digitized data? There are algorithmic approaches to detect these anomalies. So say, for example, if you haven't put in arterial line at the very beginning, you see just the flat line that is there on the monitor. Once you put in the arterial line, then there's a waveform. But if you're capturing the data, it might say 240 by 240 at the very beginning. It doesn't make any sense. Or if the A line is arterial line is overdamped and it's just basically a flat line and it's showing you like 50 over 30, whereas the non-invasive cuff is reading 120 over 60. There are algorithmic approaches where you can exclude those values and improve the quality of the data. So there are many ways to optimize it algorithmically too. And that's how most people approach it. Instead of, there are manual ways too. So at our institution, the nurses have to validate the monitor data before it goes into the electronic health record. So yes, you can take manual approaches too. But there are algorithmic approaches. So I would say both combined depending on the use case.
I think most of the echo machine also nowadays what we are getting, it is giving the ejection fraction, IVC collapsibility index, and VTA availability also.
That's right.
Um,
That's right.
Apart from that, in the remote monitoring device also for optimization of the alarms, each companies are having its own AI like
Yes.
attached with that.
Because of the alarm fatigue and multiple alarms across continuously causing the alarm fatigue. So there are now, I think, all these leading companies are coming up with their own AI based algorithms and softwares to filter them out.
But I think that's a great opportunity because they're developing these. They need clinicians like yourself. They
True.
need
We
experts
had
like yourself. So that's a
we are
great
working
opportunity.
on one such project with Triple IT right now.
Yeah, yeah. So that's a great opportunity. Thank you, and thank you for sharing that leading example.
Mm.
So we will take your help in that. I think we will. You gave us as a lead that chai samosa works with them, so we will this time serve them chai samosa.
That's
Okay,
my favorite.
Ramesh.
That's my favorite snack, but I'll leave it to you. Which one is your favorite?
Sure, sir. I think that's what the questions we have right now. Thank you, sir. Thank you, Piyush, sir,
Sure.
for joining us in the early morning, 8 o'clock, I think. Um, uh, Thank you, Venkat, sir, for joining with us.
Yeah,
Thank you, all
so
the
it's
delegates.
a homecoming for Dr. Piyush, and it's a privilege for us to have him on. So he
Mhm.
has been a faculty, a permanent member of all our national congresses in different parts of India, including Kochi and recently with
Sir,
Chennai. So we hope Dr. Piyush continues to contribute to his own um, country here back in India, also his own contributions in both AI and healthcare. Thank you, Dr. Piyush, for this.
I I always will. Thank you. Thank you, everyone.
thank you.